and welcome to A Sound Constitution, here on CHLY 101.7 FM, a show where we focus on health topics that are important to our community. This year's team is made up of 6 VIU nursing students, and our goal is to demystify health issues and address common misconceptions by sharing evidence-informed information from a variety of reliable resources. All information provided on our show will be available in our show notes on our Facebook and Instagram pages. We want to remind our listeners that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. If you have questions or concerns about what's being discussed, feel free to reach out to us on Facebook at A Sound Constitution, on Instagram at CHLY A Sound Constitution, or email us at asoundconstitution@gmail.com.
We begin today by acknowledging that we are gathered on the unceded and traditional lands of the Stigma people, whose rich cultural history continues to inspire and guide us. Our broadcast also extends into the territories of the Coatsan and the Slayaman nations. We are deeply thankful for the Stigma people's enduring connection to this land and for the opportunity to live, learn, and work here today. We make this acknowledgement with a commitment to honor and respect Indigenous cultures, traditions, and histories, and to actively participate in the ongoing work of truth and reconciliation. For more information on the ongoing reconciliation work and land acknowledgement practices of the Stigma people, we invite you to visit our Facebook, Instagram, and YouTube pages.
Hey everyone, it's Brianne here, and I'll be hosting this episode titled Beyond the Label, Understanding Mental Health and Breaking Stigma. You'll also be hearing from my co-hosts, Sophia and Finley, as we take a closer look at some of the most commonly discussed mental health conditions, especially in the last couple of years. Mental health is a topic that affects us all in some way, yet there's still a lot of misunderstanding and stigma around certain disorders. We'll be starting with ADHD. Why are diagnoses on the rise, and what accommodations actually make a difference? Then we'll explore schizophrenia through the powerful words of Eleanor Longden, who shares her lived experience of hearing voices. Next, we'll tackle a common point of confusion, the difference between bipolar disorder and borderline personality disorder. What sets them apart, and what type of therapies are actually helpful? And finally, we'll talk about anxiety. How do we distinguish between everyday stress and an anxiety disorder? When should someone seek help, and what strategies can be used in the middle of an anxiety attack? But that's not all. We'll also be diving into some important bonus topics, including cannabis-induced psychosis and the health impacts of vaping. With the increasing use of cannabis and nicotine products, especially among younger people, it's essential to understand how they can affect the brain and contribute to mental health challenges. So whether you're tuning in for personal insight, professional knowledge, or to support a loved one, stay tuned as we challenge misconceptions, explore real solutions, and open up the conversation around mental health. Getting our episode started is Sophia, and she'll be teaching us all about ADHD.
Thanks, Brianne, and thank you for listening to A Sound Constitution. Today I'm going to be answering the question, what is ADHD, and has there been an increase in diagnoses in recent years? So, what is ADHD? ADHD stands for Attention Deficit Hyperactivity Disorder. ADHD is a neurodevelopmental disorder. That means it affects how the brain develops. The Cleveland Clinic explains that ADHD, despite its name, does not mean it causes a lack of attention. What it actually means is sometimes it can be difficult to control or direct your attention. People with ADHD can experience symptoms like difficulty focusing, fidgeting, or difficulty sitting still, and impulsive behaviors. But people with ADHD can also experience hyperfocus, which is often explained as getting in the zone. Symptoms of ADHD typically start in early childhood, usually between 3 and 6 years old, but it is common for individuals to receive their diagnosis into adulthood. There is no cure for ADHD, but there are medications and behavioral therapies that are highly effective in managing the symptoms associated with ADHD. It's important to note that ADHD is not an adult onset disorder. That means that people develop ADHD in childhood. Some may get a diagnosis while others may not. For some people, as they get older, symptoms diminish or disappear. Others, however, may still struggle with ADHD symptoms into adulthood. The American Psychological Association identifies 3 main types of ADHD. The following explanation of these categories comes from the Attention Deficit Disorder Association. The first type of ADHD is called hyperactive and impulsive type ADHD. This type of ADHD predominantly presents with symptoms of hyperactivity and impulsivity. The next type is called inattentive type ADHD. This ADHD type mainly presents with symptoms of inattention and distractibility. Inattentive type ADHD is what is often referred to as ADD. And the third type of ADHD is known as combined type ADHD. This is the most prevalent type of ADHD, and it is characterized by symptoms of both inattention and distractibility, in addition to hyperactivity and impulsivity. There is no single test to diagnose ADHD, so in order to receive a diagnosis, individuals must seek the advice of a specialist. In order to help determine a diagnosis, a physician may ask about symptoms or use a behavioral rating scale to measure them. They will probably also ask about the symptom history and the age at which they were first experienced. Healthcare professionals typically use the Diagnostic and Statistical Manual of Mental Disorders to diagnose these 3 types of ADHD. The following symptoms from the DSM-5 are utilized to help determine an ADHD diagnosis in adult patients. For hyperactive and impulsive type ADHD, some potential symptoms associated with hyperactivity are fidgeting with hands and feet or being unable to sit still, leaving their seat unexpectedly, for example during meetings, often feeling restless, unable to take part in leisure activities quietly, perceived as restless, hard to keep up with, or always on the go, a tendency to talk excessively. Some symptoms of impulsivity are blurting out answers before a question or sentence is complete, difficulty waiting their turn, or interrupting or intruding on what other people are doing. For inattentive type ADHD, some potential symptoms are losing or misplacing important items, often distracted by unrelated thoughts, often forgetting to complete daily activities, short attention span and difficulty remaining focused, poor listening skills and inability to pay attention when spoken to directly, unable to finish tasks or follow instructions, avoiding work that requires sustained attention and mental focus, unable to pay close attention to details resulting in careless mistakes, difficulty organizing tasks, time, or workspace. For combined type ADHD, as the name might suggest, individuals experience symptoms that fit under both of the previous categories. In order to receive a diagnosis, an individual must meet the following criteria. For hyperactive and impulsive type ADHD, they must experience at least 5 symptoms of hyperactivity and impulsivity for more than 6 months without meeting the diagnostic criteria for inattentive behavior. For inattentive type ADHD, they must experience at least 5 symptoms of inattention for more than 6 months without meeting the diagnostic criteria for hyperactive or impulsive behavior. For combined type ADHD, they must experience at least 5 symptoms of hyperactivity and impulsivity and at least 5 symptoms of inattention for more than 6 months. Additionally, the following criteria should also be met for an adult ADHD diagnosis. Symptoms should be present in 2 or more settings, such as home, work, or school. Symptoms should clearly interfere with or reduce the functioning of a person in social, work, or school-related activities. Symptoms experienced cannot be better explained by another mental health condition, such as depression or anxiety. Symptoms should not occur during the course of a psychotic disorder like schizophrenia. So, why is getting a diagnosis sometimes challenging? Has there been an increase in diagnoses in recent years? Well, the answer to that is complex. In order to understand this, we first have to explore how the diagnosis criteria has changed and evolved over time. The symptoms and types of ADHD that I previously explained represent the current diagnostic criteria based on the DSM-5. A study in the journal Missouri Medicine outlines the evolution of ADHD diagnostic criteria over the years. The earliest recorded clinical description of an attention-related disorder comes from Sir Alexander Crichton. In his 1798 book on Attention and Its Diseases, he described morbid alterations of attention that render individuals incapable of attending with consistency to any one object of education. The next prominent description of attention disorders occurred in the early 1900s when British physician Sir George Frederick Still described a number of children with a defect of moral control. His description identified a number of features typically seen in ADHD, like impulsivity and impaired frustration tolerance. A few decades later, in the 1930s, physicians Kramer and Paul Now described children with hyperkinetic disease of infancy. Their description of this syndrome closely resembled modern understandings of ADHD, such as hyperactivity, emotional excitability, and impulsivity, and inattention. In 1968, ADHD was included for the first time in the Diagnostic and Statistical Manual of the Mental Disorders, or DSM. It was included as hyperkinetic reaction of childhood. The key focus at that time was on overactivity and distractibility. In 1980, the DSM-3 was published and gave rise to the diagnosis of Attention Deficit Disorder, or ADD. This term is still commonly used today, often when referring to inattentive type ADHD. The DSM-3 also introduced a cutoff for the number of symptoms to earn the diagnosis, as well as age at onset, symptom duration, and exclusion of confounding psychiatric disorders and substance use. The term ADHD, which used today, first appeared in 1987 with a revision to the DSM-3 that combined both inattentive and hyperactivity domains into one diagnosis. The division of the diagnoses into 3 subtypes occurred in the DSM-4. And in 2013, when the DSM-5 was published, the definition of ADHD broadened significantly. The key changes that broaden the diagnosis criteria are as follows. In the DSM-4, the number of symptoms required to receive a diagnosis was 6 or more. In the DSM-5, this number was lowered to 5 symptoms for individuals who are 17 years of age or older. In the DSM-4, the age of symptom onset needed to be below 7 years of age. In the DSM-5, that age was raised to 12. In the DSM-4, the onset of impairments related to your symptoms was required to occur before the age of 7. In the DSM-5, this age requirement was completely removed. In the DSM-4, there was a requirement for impairments in 2 or more settings. In the DSM-5, this was changed to reflect experiencing symptoms in 2 or more settings. And the final change from the DSM-4 was the allowance for ADHD and autism spectrum disorder to coexist. What this means is that prior to the DSM-5, an individual could not receive an ADHD diagnosis if they were previously diagnosed with autism spectrum disorder. Another big change that has occurred in recent years is an increased awareness of ADHD. Based on the data from Google Trends, an increase in ADHD-related searches is clearly reflected. ADHD-related searches increases sharply in 2020 and has continued to rise over the past 5 years. So, now that we have a better understanding of ADHD and the diagnosis process, let's talk about treatment. A report published by the Center for Disease Control found that more than half of adults with ADHD, 55.9%, received their diagnosis during adulthood. At the time that this data was collected, approximately 1/3 of adults with ADHD were not receiving any treatment, 36.5%, while another 1/3 were receiving both medication and counseling or behavioral treatment. Diagnosis and treatment are incredibly important for individuals with ADHD, due to the fact that deficits in organization and time management can lead to major educational, professional, or financial problems, with higher dropout rates, higher unemployment rates, and lower income attainment in adults with ADHD. This study in the Missouri Medicine Journal also recognizes the major interpersonal implications that deficits can have. For example, there are higher rates of divorce documented in adults with ADHD. People with untreated ADHD are also at an elevated risk of substance use, car accidents, unintentional injuries, depression, anxiety, and suicide. In other words, underdiagnosis and undertreatment impacts far more than one's ability to focus or sit still. So, finally, what are the treatments for ADHD? The Mayo Clinic identifies the most common treatment for ADHD as some combination of medications, counseling, and education. The most common type of medications that are used to manage the symptoms of ADHD are stimulants. The Cleveland Clinic explains how ADHD medications work in different ways depending on the type, but all ADHD medications work by increasing the levels of important chemicals, which are called neurotransmitters. These neurotransmitters include dopamine and norepinephrine. Increasing the amount of these neurotransmitters helps improve the symptoms of ADHD, such as increasing attention span, reducing hyperactivity, controlling impulsive behavior, and managing executive dysfunction. Non-stimulant medications can also be used to manage ADHD symptoms. Non-stimulant medications also work on the neurotransmitters and often don't have the same negative side effects that are associated with stimulants, such as difficulty sleeping or weight loss. The effects on non-stimulant medications are similar, however, they often take longer to start working compared with stimulants. Medications such as antidepressants are also used to treat symptoms associated with ADHD since they work on the neurotransmitters as well. The next common treatment option is counseling. Counseling is a wonderful option for individuals with ADHD as it can help them learn about their diagnosis and strategies to manage their symptoms, such as time management skills and healthy relationship building. If you'd like to learn more about the treatment options for ADHD and how they work, please check out our show notes from today's episode. This is just a reminder that the information presented in this episode is for the purpose of education only and should not replace the advice of your primary healthcare provider.
It's time for Did You Know? Cannabis, also known as weed, marijuana, or pot, is now legal for recreational use across Canada, and it's become a pretty normal part of life for many people. You'll find it in vape pens, edibles, oils, and even drinks. And with this growing accessibility, there's a common belief that cannabis is harmless, or at the very least, safer than other substances like alcohol or tobacco. For some people that's true, but for others, especially young people or those with underlying mental health vulnerabilities, regular cannabis use can carry some pretty serious risks, including a little-known condition called cannabis-induced psychosis. Today, we're taking a closer look at cannabis-induced psychosis, or CIP. We'll unpack what it is, how it's different from other psychotic disorders like schizophrenia, and why it matters, especially for youth. Let's begin with the basics. According to the National Institute of Mental Health, psychosis is a mental state where a person loses touch with reality. It can involve hallucinations, delusions, and disorganized thinking. For some, it's part of a long-term illness like schizophrenia, but for others, it's triggered by substances like cannabis. That brings us to cannabis-induced psychosis, a psychiatric condition where symptoms of psychosis emerge after cannabis use. This isn't just feeling paranoid after smoking, it's a full-blown break from reality, often requiring hospitalization. A case study published in the Psychiatric Times follows a 19-year-old student called Miss J, who was admitted to the early psychosis unit in Toronto. She had been using cannabis since the age of 17 and was using it daily since starting college. Miss J had become suddenly paranoid, isolated, and convinced people were trying to poison her. After treatment and quitting cannabis, she recovered fully and returned to school, with no further signs of psychosis. So, is this just a one-off? Actually, no. Findings published in the National Institute of Mental Health from multiple long-term studies across Sweden, Germany, New Zealand, and the Netherlands show that cannabis use, especially in adolescents, is linked to a higher risk of psychotic symptoms and disorders, like schizophrenia. Some key findings. That same study found that people who use cannabis by the age of 18 were 2 to 4 times more likely to develop schizophrenia. The more frequently they use cannabis, the greater the risk. Even after adjusting for things like genetics, trauma, and other drug use, the relationship between schizophrenia and cannabis still held up. In fact, a review published by Hall and Degenhart estimates that about 13% of schizophrenia cases might be prevented if cannabis use were avoided. And this isn't just about correlation. There's growing biological evidence that supports a link. THC, the main psychoactive ingredient in cannabis, interacts with the brain's dopamine system, the same system involved in psychosis. In lab settings, THC has been shown to induce psychotic symptoms temporarily, even in healthy people. For those with genetic vulnerabilities, like a family history of psychosis, cannabis may act as a trigger. There's also early evidence suggesting that specific genes may increase a person's sensitivity to cannabis' mental health effects. So, for some individuals, smoking weed isn't just risky, it's potentially damaging to their mental health. The symptoms of CIP, like paranoia and hallucinations, often decline more quickly than in schizophrenia. But here's the catch. For some, CIP may be the first step towards developing a chronic psychotic disorder. This makes early intervention and education critical. So what can we do? Educate the youth about the real risks without fear-mongering, but with facts. Delay first use. The later cannabis use begins, the lower the risk of CIP. And screen for cannabis use in all young patients presenting with psychosis. And make sure to support those recovering without judgment. Cannabis-induced psychosis is a real and growing concern, especially among youth. It's not about demonizing cannabis, but understanding that legal doesn't always mean harmless. As more countries move towards legalization, we need to keep the conversation honest and informed, because when it comes to mental health, prevention starts with awareness. For A Sound Constitution, I'm Finley. Thanks for listening.
All right. Up next, we have a powerful TED Talk from Eleanor Longden, a researcher and advocate who shares her personal journey of living with schizophrenia. Her talk challenges common misconceptions and highlights the importance of compassion in mental health care. Let's listen in.
The day I left home for the first time to go to university was a bright day, brimming with hope and optimism. I'd done well at school, expectations for me were high, and I gleefully entered the student life of lectures, parties, and traffic cone theft. Now, appearances, of course, can be deceptive, and to an extent, this feisty, energetic persona of lecture-going and traffic cone stealing was a veneer, albeit a very well-crafted and convincing one. Underneath, I was actually deeply unhappy, insecure, and fundamentally frightened. Frightened of other people, of the future, of failure, and of the emptiness that I felt was within me. But I was skilled at hiding it, and from the outside appeared to be someone with everything to hope for and aspire to. This fantasy of invulnerability was so complete that I even deceived myself. And as the first semester ended and the second begun, there was no way that anyone could have predicted what was just about to happen. I was leaving a seminar when it started, humming to myself, fumbling with my bag, just as I'd done 100 times before, when suddenly I heard a voice calmly observe, "She is leaving the room." I looked around and there was no one there, but the clarity and decisiveness of the comment was unmistakable. Shaken, I left my books on the stairs and hurried home, and there it was again. "She is opening the door." This was the beginning. The voice had arrived. And the voice persisted. Days and then weeks of it, on, narrating everything I did in the third person. She is going to the library. She is going to a lecture. It was neutral, impassive, and even, after a while, strangely companionate and reassuring. Although I did notice that its calm exterior sometimes slipped, in that it occasionally mirrored my own unexpressed emotion. So, for example, if I was angry and had to hide it, which I often did, being very adept at concealing how I really felt, then the voice would sound frustrated. Otherwise, it was neither sinister nor disturbing, although even at that point, it was clear that it had something to communicate to me about my emotions, particularly emotions which were remote and inaccessible. Now, it was then that I made a fatal mistake, in that I told a friend about the voice, and she was horrified. A subtle conditioning process had begun. The implication that normal people don't hear voices, and the fact that I did, meant that something was very seriously wrong. Such fear and mistrust was infectious. Suddenly, the voice didn't seem quite so benign anymore. And when she insisted that I seek medical attention, I duly complied, and which proved to be mistake number 2. I spent some time telling the college GP about what I perceived to be the real problem: anxiety, low self-worth, fears about the future, and was met with bored indifference until I mentioned the voice, upon which he dropped his pen, swung round, and began to question me with a show of real interest. And to be fair, I was desperate for interest and help, and I began to tell him about my strange commentator. And I always wish at this point the voice had said, "She is digging her own grave." I was referred to a psychiatrist who likewise took a grim view of the voice's presence, subsequently interpreting everything I said through a lens of latent insanity. For example, I was part of a student TV station that broadcast news bulletins around the campus, and during an appointment, which was running very late, said, "I'm sorry, doctor, I've got to go, I'm reading the news at 6. Now, it's down in my medical records that Eleanor has delusions that she's a television news broadcaster. It was at this point that events began to rapidly overtake me. A hospital admission followed, the first of many. A diagnosis of schizophrenia came next, and then, worst of all, a toxic, tormenting sense of hopelessness, humiliation, and despair about myself and my prospects. But having been encouraged to see the voice, not as an experience, but as a symptom, my fear and resistance towards it intensified. Now, essentially, this represented taking an aggressive stance towards my own mind, a kind of psychic civil war. And in turn, this caused the number of voices to increase and grow progressively hostile and menacing. Helplessly and hopelessly, I began to retreat into this nightmarish inner world in which the voices were destined to become both my persecutors and my only perceived companions. They told me, for example, that if I proved myself worthy of their help, then they could change my life back to how it had been. And a series of increasingly bizarre tasks was set, a kind of labor of Hercules. It started off quite small, for example, pull out 3 strands of hair, but gradually it grew more extreme, culminating in commands to harm myself and a particularly dramatic instruction. You see that tutor over there? You see that glass of water? We have to go over and pour it over him in front of the other students, which I actually did, and which, needless to say, did not endear me to the faculty. In effect, a vicious cycle of fear, avoidance, mistrust, and misunderstanding had been established. This was a battle in which I felt powerless and incapable of establishing any kind of peace or reconciliation. 2 years later, and the deterioration was dramatic. By now, I had the whole frenzied repertoire: terrifying voices, grotesque visions, bizarre, intractable delusions. My mental health status had been a catalyst for discrimination, verbal abuse, and physical and sexual assault. And I'd been told by my psychiatrist, "Eleanor, you'd be better off with cancer, because cancer is easier to cure than schizophrenia." I'd been diagnosed, drugged, and discarded, and was by now so tormented by the voices that I attempted to drill a hole in my head in order to get them out. Now, looking back on the wreckage and despair of those years, it seems to me now as if someone died in that place, and yet someone else was saved. A broken and haunted person began that journey, but the person who emerged was a survivor and would ultimately grow into the person I was destined to be. Many people have harmed me in my life, and I remember them all, but the memories grow pale and faint in comparison with the people who've helped me. The fellow survivors, the fellow voice hearers, the comrades and collaborators. The mother who never gave up on me, who knew that one day I would come back to her and was willing to wait for me for as long as it took. The doctor who only worked with me for a brief time, but who reinforced his belief that recovery was not only possible, but inevitable. And during a devastating period of relapse, told my terrified family, "Don't give up hope. I believe that Eleanor can get through this. Sometimes, you know, it snows as late as May, but summer always comes eventually." 14 minutes is not enough time to fully credit those good and generous people who fought with me and for me and who waited to welcome me back from that agonized, lonely place. But together, they forged a blend of courage, creativity, integrity, and an unshakable belief that my shattered self could become healed and whole. I used to say that these people saved me, but what I now know is they did something even more important in that they empowered me to save myself. And crucially, they helped me to understand something which I'd always suspected, that my voices were a meaningful response to traumatic life events, particularly childhood events, and as such were not my enemies, but a source of insight into solvable emotional problems. Now, at first, this was very difficult to believe, not least because the voices appeared so hostile and menacing. So in this respect, a vital first step was learning to separate out a metaphorical meaning from what I'd previously interpreted to be a literal truth. So, for example, voices which threatened to attack my home, I learned to interpret as my own sense of fear and insecurity in the world rather than an actual objective danger. Now, at first, I would have believed them. I remember, for example, sitting up one night on guard outside my parents' room to protect them from what I thought was a genuine threat from the voices, because I'd had such a bad problem with self-injury that most of the cutlery in the house had been hidden. So I ended up arming myself with a plastic fork, like picnic-ware, and sort of sat outside the room clutching it, waiting to spring into action should anything happen. It was like, don't mess with me. Got a plastic fork, don't you know? No, strategic. But a later response, and much more useful, would be to try and deconstruct the message behind the words. So when the voices warned me not to leave the house, then I would thank them for drawing my attention to how unsafe I felt, because if I was aware of it, then I could do something positive about it. But go on to reassure both them and myself that we were safe and didn't need to feel frightened anymore. I would set boundaries for the voices and try to interact with them in a way that was assertive yet respectful, establishing a slow process of communication and collaboration in which we could learn to work together and support one another. Throughout all of this, what I would ultimately realize was that each voice was closely related to aspects of myself, and that each of them carried overwhelming emotions that I'd never had an opportunity to process or resolve. Memories of sexual trauma and abuse, of anger, shame, guilt, low self-worth. The voices took the place of this pain and gave words to it. And possibly one of the greatest revelations was when I realized that the most hostile and aggressive voices actually represented the parts of me that had been hurt the most profoundly. And as such, it was these voices that needed to be shown the greatest compassion and care. It was armed with this knowledge that ultimately I would gather together my shattered self, each fragment represented by a different voice, gradually withdraw from all my medication and return to psychiatry. Only this time from the other side. 10 years after the voice first came, I finally graduated, this time with the highest degree in psychology the university had ever given, and 1 year later, the highest master's, which I always say isn't bad for a mad woman. In fact, one of the voices actually dictated the answers during the exam, which technically possibly counts as cheating. And and to be honest, sometimes I quite enjoyed their attention as well. As Oscar Wilde said, the only thing worse than being talked about is not being talked about. It also makes you very good at eavesdropping because you can listen to two conversations simultaneously, so it's not all bad. I worked in mental health services, I spoke at conferences, I published book chapters and academic articles, and I argued, and continue to do so, the relevance of the following concept, that an important question in psychiatry shouldn't be what's wrong with you, but rather what's happened to you. And all the while, I listened to my voices, with whom I'd finally learned to live with peace and respect, and which in turn reflected a growing sense of compassion, acceptance, and respect towards myself. And I remember the most moving and extraordinary moment when supporting another young woman who was terrorized by her voices and becoming fully aware for the very first time that I no longer felt that way myself, but was finally able to help someone else who was. I'm now very proud to be a part of Intervoice, the organisational body of the International Hearing Voices Movement, an initiative inspired by the work of Professor Marius Rom and Dr. Sondra Escher, which locates voice hearing as a survival strategy, a sane reaction to insane circumstances, not as an aberrant symptom of schizophrenia to be endured, but a complex, significant, and meaningful experience to be explored. Together, we envisage and enact a society that understands and respects voice hearing, supports the needs of individuals who hear voices, and which values them as full citizens. This type of society is not only possible, it's already on its way. To paraphrase Chavez, once social change begins, it cannot be reversed. You cannot humiliate the person who feels pride. You cannot oppress the people who are not afraid anymore. For me, the achievements of the Hearing Voices movement are a reminder that empathy, fellowship, justice, and respect are more than words. They are convictions and beliefs, and that beliefs can change the world. In the last 20 years, the Hearing Voices movement has established Hearing Voices networks in 26 countries across 5 continents, working together to promote dignity, solidarity, and empowerment for individuals in mental distress, to create a new language and practice of hope, which, at its very centre, lies an unshakable belief in the power of the individual. As Peter Levine has said, the human animal is a unique being, endowed with an instinctual capacity to heal and the intellectual spirit to harness this innate capacity. In this respect, for members of society, there is no greater honour or privilege than facilitating that process of healing for someone, to bear witness, to reach out a hand, to share the burden of someone's suffering, and to hold the hope for their recovery. And likewise, for survivors of distress and adversity that we remember, we don't have to live our lives forever defined by the damaging things that have happened to us. We are unique, we are irreplaceable. What lies within us can never be truly colonized, contorted, or taken away. The light never goes out. As a very wonderful doctor once said to me, "Don't tell me what other people have told you about yourself. Tell me about you." Thank you.
If you're just tuning in to A Sound Constitution, that was a TED Talk from Eleanor Longden, sharing her lived experience and shedding light on the realities of schizophrenia. Her message reminds us that recovery is possible when people are met with understanding and support, rather than fear and stigma. If you missed the TED Talk or want to hear it again, you can find the YouTube link in our show notes. Now let's hear from Finley as he teaches us the difference between bipolar disorder and BPD.
Thanks, Brianne. You've probably heard the terms bipolar and borderline or BPD thrown around, sometimes casually, sometimes incorrectly. These are 2 very real mental health conditions that are often confused. They do have some overlap in symptoms, such as impulsiveness and mood swings, but they are different disorders and have different treatments. So today, we're going to break down what is bipolar disorder, what is borderline personality disorder, what is the difference, and what resources and accommodations are actually helpful. Let's start with borderline personality disorder, or BPD. According to research from the National Institute of Mental Health, BPD is a mental disorder that affects how a person regulates their emotions. Imagine feeling things so intensely that it's hard to come back to baseline, and those emotions come fast and change quickly. Someone with BPD might feel joyful one moment and devastated the next, often triggered by something others might view as minor. This loss of emotional control can increase impulsivity, affect how someone feels about themselves, and negatively impact their relationship with others. People with BPD sometimes have a deep fear of abandonment, both real and imagined. They may struggle with identity, feel unsure of who they are, and may see the world in black and white. Relationships can become intense and unstable, swinging from idealization to sudden rejection. There may be impulsive behaviors such as unsafe sex, binge eating, or self-harm. It's important to remember that these behaviors aren't about attention. They're a way to cope with overwhelming feelings. Now, not everyone with BPD experiences all these symptoms. The severity and frequency can vary a lot from person to person. But what connects many of these experiences is emotional sensitivity, rapid mood shifts, and difficulty returning to emotional baseline. BPD is not a mood disorder, although it affects mood. Instead, it's considered a personality disorder, which means it shapes how someone interacts with the world over time. Now, let's talk about bipolar disorder. According to research from the National Institute of Mental Health, bipolar is a mood disorder, a condition marked by distinct mood episodes. These episodes can be chronic, meaning it's ongoing, or episodic, meaning the symptoms come and go irregularly. You might have heard it called manic depression or manic depressive illness. These are older names for the same condition. Most of us have our ups and downs in our mood, but for someone with bipolar disorder, these mood changes are much more intense, and they can affect a person's ability to function in daily life. People with bipolar experience manic episodes. These are periods where someone might feel unusually happy, energetic, or irritable. Their thoughts may race, they might get very little sleep, and they often take on significant changes or have an excessive appetite for food, drinking, sex, or other pleasurable activities. They may also experience depressive episodes where everything slows down. They might feel deeply sad or hopeless, lose interest in things they normally enjoy, and struggle to get out of bed or function. They may talk very slowly or feel unable to find anything to say or forget a lot. Some people experience hypomanic episodes, which are similar to mania but less severe, and they don't interfere as much with work or relationships. These shifts aren't just mood swings. They're marked change in behavior, energy, and activity that are noticeable to others, and they usually last for several days or longer. Bipolar disorder symptoms usually begin in late adolescence or early childhood. Though children can be affected too, unlike BPD, bipolar symptoms tend to come in waves or episodes that can last for days or weeks. Between episodes, people may return to their usual selves. And while episodes may come and go, the condition typically requires lifelong treatment. Left untreated, bipolar disorder can impact jobs, relationships, and even lead to suicidal thoughts or behavior. But with proper care, people with bipolar disorder can live full and healthy lives. So what's the difference between BPD and bipolar disorder? Let's take a look at a few key differences. Timing. BPD symptoms are often ongoing and reactive to daily events, where bipolar symptoms occur in episodes that may be separated by periods of stability. Mood changes. BPD moods can shift within hours, whereas bipolar shifts tend to last longer, days or weeks. Triggering events. In BPD, emotional shifts are usually triggered by interpersonal stress, whereas in bipolar disorder, mood episodes can happen with or without a clear trigger. Sense of self. People with BPD may have a shifting self-image and chronic feelings of emptiness. This isn't typical in bipolar disorder. And treatment approaches. According to research from the National Institute of Mental Health, while both benefit from therapy, bipolar disorder typically requires medication, especially mood stabilizers, whereas BPD is most effectively treated with talk therapy, especially dialectual behavior therapy, or DBT. While medication isn't the first choice for BPD, care providers will use medication to manage specific symptoms of BPD, such as depression or mood swings. And now what about what these disorders are not? Neither BPD or bipolar disorder are a personal failing, just moodiness, or a reason to stigmatize or shame someone. And neither of these disorders, bipolar disorder or BPD, should be self-diagnosed. They share some surface similarities, like mood changes or impulsivity, but the underlying causes, duration, and treatment needs are very different. If you're wondering where to turn for help, there are some resources available. The National Suicide and Crisis Lifeline is available 24/7 by dialing 988 for therapy. Organizations like Foundry BC can help connect youths and adults to mental health services. If you're in crisis and local to Vancouver Island has crisis response teams and community-based supports available from 1 p.m. to 12 a.m. daily. The link will be in our show notes. And what about accommodations? What actually helps? For both BPD and bipolar disorder, accommodations that support emotional regulation, routine, and reduced stress can be incredibly helpful. This might include flexible deadlines at work or school during periods of instability, access to quiet spaces or breaks when overwhelmed, permissions to attend medical or therapy appointments regularly, using a mood tracker or a routine planner as part of a daily structure. And socially, compassion, not correction, goes a long way. Whether someone is navigating the rapid emotional shifts of BPD or the energy extremes of bipolar disorder, the goal isn't to fix them, it's to walk alongside them. Understanding the difference between bipolar disorder and borderline personality disorder helps reduce stigma, increases empathy, and leads to better care. Both conditions are valid, both are treatable, and both deserve support, not judgment. The information and suggestions you hear on the show do not replace the advice of healthcare professionals. Always consult with a doctor or care provider before starting a new medication, making big life changes, or taking a new supplement, especially if you have any health conditions. If you're interested in learning more, please check out our show notes on Spotify and on YouTube, found under A Sound Constitution. For A Sound Constitution, I'm Finlay. Thanks for listening.
There's a lot of information circulating about vaping and e-cigarette use. Today, our goal is to open the door for critical thinking, reflection, and awareness surrounding this topic and its implications on health and wellness. First, I would like to briefly describe what a vape is and the history surrounding it. A study published in the Journal of the American Academy of Physicians' Assistants explains the recent history of vapes, which are also known as electronic or e-cigarettes, were first introduced in 2004 in China as a smoking cessation device. By the mid-2000s, they had made their way into the American market. Vapes contain a battery that can be activated by pressing a button or by inhaling. There is a tank inside of the device that contains the liquid or juice. This juice usually contains nicotine, although there are options that are nicotine-free. This juice is typically flavored. The battery heats up an atomizer that is attached to it, and this vaporizes the liquid. This aerosolized liquid is then inhaled by the user. So, are vapes really any better than smoking cigarettes? Due to how new the use of vapes is, there's a lack of research surrounding the long-term impacts of vaping. A study published in the Journal of Multidisciplinary Respiratory Medicine in 2020 compared the effects of smoking cigarettes and the effects of vaping on respiratory function, cardiovascular function, and muscle function. The conclusion of this study found that the effects of vaping on respiratory and cardiovascular function was similar to that of smoking cigarettes, despite vaping often being marketed as a healthier option. This study acknowledged the lack of research surrounding the effects of vaping on muscle function and growth. There are many studies that compare the health implications of vaping and cigarette use. Many studies found that these impacts were just as harmful as the short-term effects of cigarette use. However, there are also studies that indicate that vaping is the healthier option when compared with cigarette smoking, such as an article published in the European Heart Journal that indicates it's only ingredients like vitamin E acetate and tetrahydrocannabinol in vape juice that lead to the adverse effects among e-cigarette users, like severe pulmonary disease and, in some cases, death. At the end of the day, there is a lot of conflicting information out there about vaping and its health implications. When looking for information about vaping and e-cigarettes, the important thing to remember is how new vaping is and the lack of long-term research. While there is evidence to show the effectiveness of vaping for quitting smoking cigarettes, the question still remains, is it actually healthier? I would like to leave you with this quote from a 2022 study in the British Medical Journal. Discussions regarding the potential harms of vaping are reminiscent of scientific debates about the health effects of cigarette use in the 1940s. Interesting parallels persist, including the fact that only a minority of conventional cigarette users develop acute lung injury. Yet, the health impact of sustained, longitudinal cigarette use is unquestioned. The true impact of vaping on respiratory health will manifest over the coming decades. But in the interval, a prudent and time-tested recommendation remains to abstain from the consumption of inhaled nicotine and other products. If you would like to read any of the studies talked about here today, please check out our show notes on Instagram, Facebook, or in the description of today's episode on YouTube or Spotify. Thank you again for listening to A Sound Constitution.
For our final segment of this episode, let's dive into the topic of anxiety, what it really means, when it might be more than just everyday worry, and what you can do if you're feeling overwhelmed by it. Anxiety is something we've all experienced at one point or another. Think about a time when you were preparing for a big exam, had an important job interview, or even before a first date. Those feelings of nervousness, butterflies in your stomach, or racing thoughts are normal responses. They're your body's natural way of preparing you to face a challenge. But what happens when anxiety doesn't go away? When it starts to interfere with your daily life, and when those butterflies turn into a swarm of worries that you can't control? That's when anxiety might not just be normal stress, but something called an anxiety disorder. According to the Canadian Mental Health Association, anxiety disorders involve excessive and uncontrollable worry, strong fears around everyday things or situations, unwanted thoughts, panic attacks, or fears around a past scary situation. These worries can last for weeks, months, or even longer, and they affect a significant number of Canadians each year. Normal human anxiety is a temporary, situational response to stress. It can motivate us to prepare and perform well in challenging situations. For instance, feeling a bit anxious before giving a presentation might push you to rehearse more and be better prepared. On the other hand, an anxiety disorder is different. It's not just about feeling nervous once in a while. Instead, it's characterized by ongoing worry and physical symptoms like a racing heart, sweating, trembling, dizziness, or shortness of breath. In Canada, it's estimated that approximately 1 in 10 people experience an anxiety disorder at some point in their lives. So how do you know if what you're experiencing is more than just normal anxiety? Well, here are some specific signs to be on the lookout for. As I already mentioned, persistent and excessive worry. If you find yourself worrying most days for an extended period, often about everyday things that wouldn't usually cause such concern, that's a red flag. And if you start experiencing any of those physical symptoms that I mentioned, such as a racing heart, sweating, trembling, dizziness, or shortness of breath, that's another red flag. Sometimes these symptoms might even feel as though you're experiencing a more serious physical problem, which only adds to the worry. Something else that often gets overlooked are sleep problems. Difficulty falling or staying asleep, or waking up in the morning still feeling exhausted, can indicate that anxiety is taking a toll. Avoidance behavior can also be a point of concern. If anxiety is causing you to avoid certain places, situations, or even people because you're afraid of feeling overwhelmed, that's something to be on the lookout for. And if your anxiety starts preventing you from doing routine activities such as going to work, socializing, or partaking in your hobbies, it's definitely time to seek some help from a qualified professional. If you notice any of these symptoms persisting for more than a couple of weeks, or if your anxiety begins to interfere significantly with your daily life, mental health professionals in Canada are available to help diagnose the issue and will work with you to develop a treatment plan, including therapy, medication, or a combination of approaches. Now let's shift our focus towards some practical strategies for managing anxiety, especially during an anxiety attack. An anxiety attack can feel overwhelming, but there are several techniques that might help you regain a sense of calm. The first and most well-known strategy is deep breathing. One of the simplest ways to calm your mind is to take slow, deep breaths. Try this specific technique called box breathing. Breathe in slowly through your nose for a count of 4, hold your breath for a count of 4, and then exhale slowly through your mouth for another count of 4. Repeat these steps as many times as you need to. This technique is shown to help slow your heart rate and can reduce the intensity of your anxiety. Another strategy is called grounding. When you feel overwhelmed, grounding exercises can help bring your focus back to the present. For example, use the 5-4-3-2-1 method. Name 5 things you can see, 4 things you can touch, 3 things you can hear, 2 things you can smell, and 1 thing you can taste. This method helps distract your mind from anxious thoughts and helps to anchor you in the present through the use of your 5 senses. One strategy that has really helped me in the past is progressive muscle relaxation. This involves tensing and then slowly relaxing each muscle group in our body. Start with your feet and then move up to your legs, torso, arms, and face. This practice can relieve the physical tension that often comes with anxiety while diverting your attention from anxious thoughts. Something that I'm sure we've all heard about at one point in time is mindfulness meditation. Mindfulness is about being present in the moment without self-judgment. Find a calm and quiet space, sit comfortably or even lay down, and focus on your breath or a calming word. The key to this technique is basically to make yourself as comfortable as possible without falling asleep. Even just a few minutes of mindfulness practice each day can reduce overall anxiety levels. Another excellent method that works really well for me is physical activity. Sometimes a short walk or really any form of exercise can help burn off that nervous energy and release endorphins, which naturally boosts your mood. I myself find a lot of relief in exercising my dog, either at the dog park or on a stroll around the neighborhood. And finally, sometimes the best strategy is to talk it out. Sharing your feelings with a friend, family member, or mental health professional can help get anxious thoughts out of your head and lessen the intensity of them. And if you're someone that feels better after a good long cry, allow yourself to have that emotional release. It's just another way of burning off anxious energy and helps to clear your mind so you can calmly address the source of your anxiety. Remember, these coping strategies aren't one size fits all. It might take some time to figure out what's best for you, and that's perfectly okay. It's important to experiment and be patient with yourself as you navigate what feels most comforting. Anxiety disorders can affect anyone, no matter their age, gender, or socioeconomic status. 1 in 10 Canadians will experience an anxiety disorder at some point in their lives. Beyond its emotional impact, persistent anxiety can have significant effects on physical health, including an increased risk of high blood pressure and heart disease. Despite its prevalence, many people hesitate to seek help due to stigma surrounding mental health. However, just as one would visit a doctor for persistent physical illness, addressing anxiety through professional support is an important step towards overall well-being. Aside from stigma, I would be remiss if I didn't acknowledge the significant challenge in accessing mental health care in Canada due to the shortage of mental health professionals. Long wait times for psychiatrists, psychologists, and therapists can make it difficult for individuals to receive timely support. This can be incredibly frustrating and disheartening, especially for those who struggle just to reach out or those in need of immediate intervention. However, there are alternatives available. Many provinces offer free or low-cost mental health resources, such as crisis lines, online therapy programs, and community-based support groups. Virtual mental health services, including telehealth counseling and self-guided CBT, which means cognitive behavioral therapy, have also become more accessible, helping to bridge the gap while individuals wait for the in-person care they deserve. Ultimately, though, early intervention plays a crucial role in managing anxiety. Recognizing symptoms early and implementing coping strategies, such as therapy, medication, or lifestyle changes, can prevent anxiety from becoming debilitating. Public awareness campaigns and open discussions about mental health have definitely been on the rise as of late, but continuing these efforts is essential in reducing stigma and encouraging those who are struggling to reach out for support. By fostering a supportive environment, both societally and at home with their loved ones, more Canadians can access the mental health resources they need to manage anxiety effectively. And that brings us to the end of today's episode, where we explored ADHD, schizophrenia, bipolar disorder versus BPD, and anxiety, breaking down common misconceptions and highlighting real practical solutions. We also touched on the health impacts of cannabis-induced psychosis and vaping. Mental health is a complex issue, but understanding these conditions is a crucial step towards reducing stigma and providing meaningful support. If you or someone you know is struggling, don't hesitate to reach out for help. For BC residents, a great place to start is by calling 211. This is a free, confidential, and multilingual service that is available 24 hours a day, 7 days a week, to help connect you to the right resources and supports. There is also the National Crisis Line that offers emotional support and information in a crisis without a wait or busy signal, and that number is 310-6789, no area code. More information and resources can be found on the HealthLink BC website under the Mental Health and Substance Use tab, or by simply calling 811. Thanks so much for listening to our show today. For details and show notes, including our references, check out our Facebook page at A Sound Constitution on 101.7 FM, or our Instagram at CHLY A Sound Constitution. We want to remind our listeners one more time that the information presented in this show is for educational purposes only and does not replace the advice of your primary healthcare professional. If you have any questions or concerns about what was discussed today, please feel free to email us directly at asoundconstitution@gmail.com. And if you missed any of this episode or want to check out our other episodes, you can head over to our YouTube channel or our Spotify page at, you guessed it, A Sound Constitution. Thanks again for listening, everyone, and we hope you all have a wonderful rest of your day.